Good afternoon and welcome to our fourth Celebrate One Lunch and Learn session. My name is Khadija Torian and I am the Senior Manager of Pregnancy and Perinatal Support. In today's theme, we will be ensuring safe deliveries and continue to. Hey, we will be continue to learn and connect and uplift our community and health professionals in the maternal health space. And I'm just so glad you all had an opportunity to join us. So I will introduce our first speaker and we will begin. I would like to start with Dr. Camila Dixon, is an associate professor of OBGYN at the Ohio State University Wexner Medical Center Department of OBGYN, where she serves as the interim director of the General Division, vice chair of Diversity, Equity, and Inclusion, and the medical director of Moms to Be, which is a community-based pregnancy and postpartum education and support program to decrease the infant mortality rate. She is committed to ensuring that all have access to the very best care. She is a member of the Pregnancy Associated Mortality Review Committee and co-led for the Compassionate, Accountable, Respectful, and Equitable Care Project with the Ohio Perinatal Quality Collaborative. She completed her undergraduate studies at Harvard University with a degree in biology. She then went on to teach high school biology with Teach for America in Washington, D.C. She completed her medical training at the Georgetown School of Medicine and her residency training at Baylor College of Medicine in Houston, where she served as administrative chief resident in her final year of training. She has been awarded top doctor awards from Castle Cannoli and was named as a 40 under 40 leader in minority health lead by National Minority Quality Forum. So whenever you are ready, Dr. Cami, the floor is yours, Dr. Cami.
Awesome. Thank you so much for having me. Thanks for everyone for being here. I'm super excited. It's so good to see so many familiar faces as we've worked in this space for many years now in Columbus. I think this is such a wonderful idea. I do have some slides. I don't know what the vibes are, if people want to see slides or not. I'm happy just to talk through some things, but I guess we can try. I can first see if I can share the slides. If I can't, then, that's just what we got, right? So let's see what we can do.
Yes, all warm space community conversations were chill.
Okay. Okay. We've been chill. Okay.
Yes,
Let's
chill.
be chill. Okay. Perfect. I think I'm really excited for us to get together, just to kind of talk about just the different roles that we have for birth workers in this space and how really, I mean, I think the punchline that I think we'll all come to is that we all work together really well. And it's really important for all of us to be involved in this to make sure that people have access to the best health possible. So, as far as an OBGYN, what we do is that, we take care of people during pregnancy and also outside of pregnancy. So we provide healthcare, reproductive healthcare to people throughout their entire lives. When we break it down, we have the obstetrician and then the gynecologist. So the obstetrician is the part that takes care of pregnancy. And we will do prenatal care, we'll do deliveries, we'll also take care of people in the postpartum period of time as well. And then also prepping for delivery too. So in the preconception time, which is super important, especially if people have underlying health conditions that need to be optimized before they get pregnant to ensure that they have a healthier pregnancy. And then the gynecology side is more of the reproductive health side. So we do things like birth control, STI testing, helping patients with abnormal bleeding, with menopause. And that's probably more of our surgical side. I think one of the first questions I always get from people is, as an OBGYN, they sometimes don't think that we do the procedures we do. So if a patient we're taking care of needs a C-section, we'll do the C-section. If we have a patient who has heavy bleeding and needs a hysterectomy, we'll do that. And of course, there's lots of specializations within OBGYN, but I am a generalist because I love it all. I love taking care of my patients during pregnancy. I love doing C-sections. I love doing a really great vaginal birth. But I also love it if I have a patient who is not pregnant, who has heavy bleeding and needs a hysterectomy, and I can provide that service as well. As far as the education that one needs to be an OBGYN, so typically people complete their 4 years of a bachelor program. And there are specific prerequisites that you need to have in place to be able to then apply to medical school. So there's math requirements and chemistry and biology. So you get those done. the really cool thing is you don't necessarily have to be like a science major. One of my best friends actually is an art major and she's an orthopedic surgeon. So she completed all her other coursework and then was able to major in art. I was a biology major. I'm like, let's just make this easy. This is what I like. So I'm going to study this and then be able to use this as I apply to med school. Once you apply to med school, you have to take a test called the MCAT. So you do that, and then you do your application. And if you're accepted to medical school, they are typically 4 years. There used to be some combined schools in the undergrad and medical realm where you can do like 6 years. They've kind of, I actually don't remember if they still exist. They've kind of been phased out a little bit. But here, at least in the United States, there's kind of just those two separate ones. And then when you finish medical school, you go to residency, and that is 4 years as well. And then you're out to practice. But yeah, I feel like I'm rambling here. So I guess I'll just pause for a second.
No, you're fine. I'm getting used to like the webinar function, so I'm watching the chat, making sure if any questions come along,
Okay.
we'll ask those. But could you also share a little bit like the importance of why we need OBs coming from the communities that we live in and serve? Like, what is the importance of that?
Yeah, no, it's super, super important. We know that concordance in care, when patients have doctors who look like them, they're more likely to get their preventive healthcare screening. They're more likely to feel comfortable in their labor process. We also know that unfortunately there is not a high number of, especially speaking to Black OBGYNs, there are not many of us. In Columbus, there's like a handful, and we all kind of meet and get together and try to work together. At OSU, we currently have two, and my partner just dropped down and she only does gynecology. So now it's just me, which is I'm like, if anyone wants to come practice OB at Ohio State, we're hiring and welcome. But it was in preparation for this talk, I was actually looking at national statistics as well. And the rate of OB-GYNs that are like Black OB-GYNs nationally is about 9%. Like it's not high. So a lot of that comes down to how are we making sure that people know, like one, that's a specialty, how do we make sure people get access to this education and are supported to be able to do that? Because it's really, really necessary. But that's also another reason why collaborating with our midwives and our doulas and our community organizations are super important because like, as I just said, concordant care is super important. And if it's just me providing it, I can't do it, right? I can't do it myself. I need to work with so many great organizations like Root and like other organizations in town. So yeah, it's super important.
Thank you for that. And this was not sent over, so please be like, Khadijah, you did not say that. But as you were speaking, I kind of had a thought, like for the moms that are, in the community, they're having babies, but OB is something that they are thinking of. They want to go that career route, but they have additional barriers and challenges, whether that is like a partner or a spouse that's away for whatever reason, or they have, 4 kids and no support to watch. Like, what is some advice to continue to that career path and to actually increase the percentage of Black OBs in
That's a
Columbus?
that's a really excellent question. I mean, I think the first thing is this is where the power of mentorship is so important. And whether it's someone who's local or someone who is just like, I've mentored people from not in Columbus before, and just reminding people like you can do it. What's really crazy to me is that I think most of my friends, especially my friends who are women doctors and women doctors of color, at some point in their career have been told, don't go into medicine or you can't go into medicine. That's what they told me when I was, right? It told you too, Jessica, right? Like they'll tell you that. And when I was teaching and I said, I want to go back into medical school, I went and had to meet with some advisors and they were like, you should be a teacher. You don't have to be a doctor. And I like think back on that often. If I just believed that, I would have missed out on so many rich experiences and missed out on the opportunity to really serve my community in the way that I think I was built to serve them. So I kind of want to pass that along to people too. There are going to be barriers, and I'm not trying to say that like it's easy when you have 4 kids and you're studying and you're working and doing like that is really hard, and it's important to give yourself grace knowing that it is hard, but the goal is so important, and like don't get discouraged from that.
Thank you. And then what would you say are some challenges? Okay, now we're on the other side. We are OBs now. What are some challenges in that space that we can know about in the upfront?
So like as far as being an OB or
Yes,
like
like once your foot in the door, what are the challenges? Now I'm a black African American mom, OB. What are some challenges once I'm over there now to expect?
Yeah, I mean, I think it's one of those things where because there's so few of us, right? I mean, I think sometimes people's eyes are on you, right? So you can feel like a lot of pressure in that way. Um, Sometimes there are spaces there's a lot of microaggressions that can happen. I've had that happen in my career where you show up, you're wearing a white coat, you walk in the door, and they're like, I think dietary's here. I'm waiting for the doctor. I'm like, I'm Dr. Dixon, I'm here. That's unfortunately still happens, right? You walk in a room, especially if you're younger, people have a space in their mind of what an OB or what a doctor looks like. Typically, people think of like an older white man. Like that's what people think of when they think of doctor. So when you don't match that, sometimes people are like, "Are you here? Like, did you even do the work?" Yes, I'm here, and I've been doing this for a minute. So I think that that can be a challenge, but something that you just have to know is unfortunately part of the process and important for you to continue to show people that no, there are other people who do this work and do it well. I also think that making sure that you make the time for your family and your things that really like fill you are super important, right? So a lot of times we have this desire to do the best job we can, and like we're just burning the candle on both ends, and it's important to like step back and be like, okay, this is super important, but also making sure that I can come back and serve my patients in the best way possible is important too. And so for me, it's like finding the things that rejuvenate you, whether it's like hang out with family and friends. For me, it's like live music. Like I get live music, I'm good. I can get going for the next day. But not throwing that away because you just won't be able to serve people well.
Thank you. Thank you for that. And then with that being said, on the other side, what are some successes or feel goods about being a OB that one could look forward to?
I love it. Like I really do love my job, and I think I feel really lucky and blessed that I get to do it. When I was in medical school, I admittedly didn't really like any other specialty, so I'm really thankful that I was able to be an OB because I wouldn't have been a doctor otherwise. I love taking care of my patients. I have a patient who I've had patients who I've seen, in one relationship, failed relationship, pregnant, new family, like, and it's just like really exciting. I've had patients where I've taken care of them for their first baby and their sixth baby, and it's just like really cool to see that progression. I've had patients who have experienced early pregnancy loss and then go on to have their first baby, and it's just being in that room is just so amazing. And you're like, everyone's crying, and baby's crying, right? But everyone's crying, and like it just feels so good because you just know that you hopefully had a hand in this, and you also just feel lucky that someone trusted you, right? So like that is probably the best thing about my job.
Thank you. Thank you so much. And before we move on to our next panelist, I have one more question for you, Dr. Cami. And what would you say is the one thing that makes you the OB that makes a difference in the community?
Oh, that's a really good question. I think it is because I try very hard to make myself available, right? So like this example, right? Like I love it. I love being in the community. So I love talking to people. I love connecting with people. I love being a resource. And I think especially because sometimes that knowledge is like kept away, right? Only certain people have knowledge of certain things. I hate that. And I think my goal in my career is to make sure people have accessible knowledge, have accessible healthcare, have excellent healthcare, and can just feel confident in the care that they're getting. And however way I can do it to help facilitate that, whether it's I'm personally giving the care or I'm teaching my residents how to give that care, or I'm a phone call if you're having a consultation with another doctor, like whatever it is, like that's kind of what I see my role as.
Thank you so much. Okay, we are going to get right into our next panelist, Jessica Roach, as our midwife. So I'm going to read our bio and then I'm going to pass over to Mike. So, Jessica Roach is the Chief Executive Officer and founder of Restoring Our Own Through Transformation, known as ROOT, a Black woman led organization advancing reproductive justice and Black family stabilization. With over 25 years of experience across neuroscience, pediatrics, and maternal child health, Jessica blends clinical expertise with lived experience as a nurse, midwife, doula, mother, and advocate. Her work dismantles systemic racism in healthcare through community rooted education, advocacy, and care. Her nationally recognized web of causation framework addresses the impact of structural and social determinants of Black health, Jessica's leadership has helped significantly reduce maternal and infant mortality rates and continues to inspire transformation rooted in equity, healing, and historical truth. Jessica's unwavering commitment to reproductive justice, health equity, and the well being of Black mothers, fathers, families, and children continues to inspire long term transformative change. Through her work, Jessica envisions a future where preventable deaths in motherhood and infancy are eradicated and health equity is achieved for all. And Jessica, whenever you're ready, the floor is yours.
Thank you so much. I appreciate that introduction. So again, my name is Jessica Roach, and since we're casual and we can just
Yes.
talk, everybody, I am really honored to be here today to be able to talk about some of the work of being a midwife, and should also be very clear that I am not actively practicing as a midwife right now. I will be going back to that at some point, but more important to be working with Root and to be working to build that system, so that we can be in the place of being able to do the each one teach one, which is a primary principle within the construct and now. So, yes, I am a nurse, I am a midwife, I am a doula, I am most importantly a Black woman, I am a mother, and I have multi generations that are coming at this point. So that's also very exciting for me. I have been in this work again for about 25 years, which is going to date me, I'm quite sure. And I've been in this work starting out again as a nurse in neuroscience, which was always very interesting to me, and didn't really understand the full length of that until I fully got into doing birth work, and then worked as well in pediatrics. Worked as a labor and delivery nurse for a brief period of time, and then moved into working as a midwife. My primary reason and motivation for doing that was because I'm also a woman with lived experience. So, my first child, I had her when I was a teenager, technically had all of the risk factors that are associated when we look at the social determinants of health singularly. And that pregnancy was actually quite wonderful. It was post due dates, and we never had really any issues from a medical perspective. My second pregnancy, however, was one that was a significant challenge. This was after I already had my degree in nursing. I was working as a research nurse at the Ohio State University at the time, and I had a pretty challenging. I'm sure a lot of these terms have been thrown out to women as well. They had the incompetent cervix, had issues with hypertension, had preeclampsia, and then ended up having a preterm birth with a child that did have some slight medical issues at the beginning. The main difference between those two pregnancies was that with my first one, I had a significant amount of support from my family. It was not something that was an abnormal in our family to have children at certain ages. I still had my great grandmother, I still had my grandmother, my father was very much engaged, involved. Very, very strong family roots. And so there was never anything that was associated with it that was a problem. So I didn't know that that was a problem. The second time around, it was very, very high stress. Being one of only two Black nurses in the entire department, the other Black nurse being my mentor and also the person that attended my birth with me. Um, and having to live inside of that situation where it's very obvious that Black women and women of color have to perform and achieve at like 150%, where sometimes our colleagues can get away with 70 to 80%. And so the microaggressions that are experienced, the racism that is experienced, and then also, being a mother that gave birth in the same hospital that I worked for, nobody knows your initials. They don't look at you and see your initials. And so it was very obvious and clear that the treatment, um, based upon who I was and what I looked like, was a little bit different with some of the staff members that were on the floor. Um, and then moving into having my third child, I decided that I wanted to have a home birth because I had a fear of being back in the hospital, like so many of us talk about. And I felt much more confident in being able to return to the root of my upbringing and the things that I had been taught and the things that I had learned. And I felt that that was going to be a safer place for me. And so I had a home birth midwife. I had a wonderful physician that was a co-collaborator in co-care with my midwife. This is in Arizona, and so it's a little bit different as far as the laws are concerned and the misconceptions and those types of things because we have very different populations in Arizona. So we have to cover that type of care. And so out of that, it is what came into. I knew that this was something that had been one passed down through family. and my generations, and two, something that I was really called to, and knew that the story that was being told about us was just a story. It wasn't actually the correct narrative, that we were fully capable. And it was possible for us to be able to have children and not die. That didn't have to be the story. That's not the first thing that you should know. And also going into public health as a master's of public health, in maternal and infant health, it is very interesting when you take a look at what risk factors are. And behavior, one of the behavioral risk factors that's associated is being Black. Black is not a behavior. Black is who I am. So what you're saying is that who I am is in essence why it is that we have these outcomes that we do. And that's absolutely not true. 70 to 80%, depending upon the study that you look at, of the issues that cause any type of severe maternal morbidity, mortality, and also infant mortality can be preventable. Why do I say it in that way? Because the only way that you're going to get to a healthy child is if you have a healthy mom. And if you do not support in a way that can produce a healthy mom, looking at all aspects of that care, there can be some concerns and issues with the child. That's not saying anything about congenital defects, all of those things. But when we really take a look at the stats, and I'm a big stats person because the stats don't lie to a certain extent, there's always bias and there can always be a confounding factor, but they really don't lie when you take a look at all of that together. You take a look at these stats and you see that we should not have the health statistics that we do. One, because when you take a look at why those things happen, they're things that are very easily preventable. They are things that are very easily mitigated. And there are some things that there absolutely cannot be tied to anything that is genetic or biological. When we talk about overall infant mortality, number one issue for infant mortality in our communities is preterm and low birth weight. Well, how do you create a baby that's preterm and low birth weight? You have a mother that's incredibly stressed out. She may have a low hemoglobin. She may not know that there are certain things that are tied to being able to produce a baby, like higher levels of protein, making sure that you're drinking a lot of water and flushing out your kidneys so that you don't develop preeclampsia, making sure that you're mitigating your stress factors because things like cortisol interfere with actual neurophysiological development. Those things are very easily understood by us as individuals. All we need is someone to be able to connect the dots. And the minute those dots get connected, outcomes change. I've always been taught by the midwives that mentored me, and I have to give thanks and honor to all of those that have come before me and having the responsibility to be able to move that forward, is that our only job at the end of the day is to bear witness and be in the room. Because if everything else is working the way it is and we actually did our job the way that we're supposed to, there really isn't much of a need for us because it's going to just happen. You have to trust birth. And I'm a medical person too. So I'm very clear about that line. You have to make sure that you're paying attention to everything that is happening. You have to make sure that you're taking a look at those very real risk factors. You have to look at those pre existing conditions. You have to take a look at a track and a trend over time. And then you also need to make sure that you break those down. Was this caused by there being a very real physiological or pathophysiological process? Or was this caused because of the fact that you were working like I was during my pregnancy, 60 to 70 hours a week, being on call constantly, always on my feet, not drinking enough water, not stopping to eat, all of those things. Stress because I'm literally walking inside of an area that is both micro and macro aggressive and having to take all of that in and process it while trying to be pregnant. So that's why it is that we do the work at Root that we do. That's why we have the phenomenal people that work with us. That's the makeup of our staff, and I actually have to give like at least a few shout outs for folks, but that's why we harbor and support the atmosphere that we do. We have folks that have come to us that were clients and have completed their own degrees because they wanted to be either a nurse or wanted to be in health administration. Um, they may already had an MSW when they came in, and they've completed their LSW. We have a staff member that's getting ready to go to medical school, and she's going to be an OBGYN. And we're going to make sure that that is supported because part of making sure that we can take care of one another is making sure that we can help produce those in the workforce that look like us, that have been through those experiences, that are going to better relate to the issues and concerns that we have on a daily basis so that we can get to the outcomes that we need to have.
Thank you, Jessica. And I have a few questions for you. So, one, are you currently aware of Ohio's stance on midwifery?
I am actually. So Ohio is a very interesting state when it comes to midwife. And so you're saying this is a kind of a broader generalized piece, right? Because there's several different types of midwives. There are those that are consider themselves traditional midwives. I would be one of those. I did that as a matter of politics and a political stance that I wasn't going to complete what is the certified professional midwife testing. And I didn't want to go through certified nurse midwifery because of the traditions that we hold as Black women throughout history and what we brought to this country and how it is that midwifery actually was created. So there's those. There's also those that are CPMs, which are certified professional midwives. Those are the ones that most people think of when you're thinking about home birth. Right. So you think about home birth, you think about a certified professional midwife, but CNMs can also do home births as well. So those are nurse midwives, obviously, and they primarily work in the hospital. They work concomitantly in care with physicians primarily, and they can actually do home births in the state of Ohio, but they do have to have that collaborative agreement with a physician that will back them up. So there's actually a little bit more leeway with a certified professional midwife now than there is with a certified nurse midwife. A certified nurse midwife is much more regulated. The stance in Ohio, as far as home birth is concerned, is a little bit muddy. And it's a little bit muddy only because certified professional midwives are considered at this point illegal, meaning they're not legal, they're not illegal. So there's a very gray area that happens in that. What does come into play sometimes is that in like certain situations with me, which is why one of the reasons why I'm practicing currently as an active traditional midwife, is that if you carry another medical license inside of the state of Ohio and you operate and do any type of home birth, it can be considered working like it can be considered a felony practice. And so it kind of jams up in that way where it doesn't give us a lot of room to be able to do those things. And then again, with a certified nurse midwife, you can again do those home births primarily to do work, operate in a hospital, which is I think an awesome, great space. Also, primarily work in birth centers, and you'll find that a lot of times when you're talking about birth centers, um, that conversation gets really gray too. But certified nurse midwives have much more autonomy, even with the collaborative agreement inside of birth centers, because they'll ultimately be the ones that are offering most of the primary care. You can also have a crossover with those that are family medicine, but they're family medicine OB that can also operate inside of a birth center. And so again, it's a very interesting state that we're in. I know that there has been lots of legislation that I've been involved with, some legislation that I have not been involved with, different variations of legislation that have come up in regards to the regulation of certified professional midwives specifically, but not talking about those community midwives or those traditional midwives. And it's like come up and then it's gone under the radar. And so we're still in that process. I know there's yet another bill that is being worked on, another piece of legislation that is being worked on as we speak. That could get into some arena where certified professional midwives would be recognized and regulated in the state of Ohio. But then those community midwives and traditional midwives may ultimately, because of the language of that legislation, could become illegal, which could open up some other concerns and issues. While I'm very clear about the fact that we do need to have some parameters around um, training and safety, I think that they come from, and I know that they come from multiple tracks that are not necessarily within the construct of the paradigm of those primarily white institutions that we're used to going through. But they also have a history of even being created from those that were indigenous midwives. Those were black midwives. Those were like very specific population Italian immigrant midwives. Those curriculums have actually came out of that history that we hold as Black birth workers. And that those things need to be recognized, and that's not something that can be regulated, because obviously we've seen over time through the structural determinants that have created the social determinants, how regulation actually negatively impacts us on a policy level.
Thank you. And Jessica, what advice would you give, like our apprentice, our community members who are considering being a midwife? How would they choose a program, or like what do they need to know to choose a program? And then also, any advice to family, community members who are expecting and want a midwife? How would they go about finding one?
Those are really good questions. They're really good questions that are somewhat in depth that I don't think we're going to get totally into or be able to completely complete. But I definitely echo what Dr. Cami said is that one, do it. Don't let anybody discourage you. Find a mentor. One of the major things that changed my life and trajectory in my career is that the first job that I had, luckily enough, when I graduated from nursing school and went to work at Ohio State University, was that I had a Black nurse practitioner who took me on, changed the game, changed it all, right? So find those in your community that have done this work, and make sure that you stay highly encouraged. And every time that they tell you that it's not a possibility or that you have too many things on your plate or whatever the case may be, just know that that's a lie. It's not true. But you do have to create your village. You've got to make sure that you've got that support. You've got to make sure that you've got great self care, which I know that some of us on this call have not necessarily had and have started learning much more through some of our colleagues that are now coming up that are very clear, like, hey, we're not going to operate like that. And neither are you, because we need you to stick around, right? Um, Make sure that you look at what you are wanting to do and then decide upon what the trajectory is. If you're looking to do more like be a home birth midwife, there are schools that you can go to that will help support you. I have to give a shout out to Jenny Joseph, who has the only Black-led school of midwifery for home birth midwifery, according to the guidelines of the CPM in the country. That program is also a hybrid program, so it can be either on site, it can be on site and off site. Finding a preceptor can sometimes be a little bit of a challenge, but there are pathways and avenues to be able to do that work. If you are looking to want to be able to be in a hospital, which I think is actually ultimately really important for us, in particular as Black women, because we're not always going to be able to have access to being able to have a home birth. And home birth is not for everybody. I need that to be very clear. It is not a magic wand. Just because you have a midwife doesn't mean that like everything's going to be rainbows and butterflies. And all of us know you cannot get to a rainbow without a storm. So you got to keep all of that in mind. But becoming a nurse is a really great way to do so, and we need more Black nurses. Like, I will be a nurse for the rest of my life, even if I'm not working on the floor. We need more Black nurses. We need more Black nurses because we need them for we need us for each other. We need to be able to have that nod and be like, I see you, and be able to come together and work with one another. We need to be able to provide each other that support. And because we have most of us that are still giving birth inside of a hospital, what is the best way to be able to be protected and held and get that type of information that we need and to be able to get the level of support? It really does come through culturally congruent care, which means having more people that look like us serving us and more people that have been through our experiences, more importantly, because you can look like us and not necessarily have had the same experiences, but those that have had the same experiences, those that look like us, being on the floor, having access to care to be able to care for us is really important. And there is a burden. And I'm going to say that as an advocacy place, you know, Dr. Cami is one of two at Ohio State, right? We have very few across the city. It is incredibly challenging speaking as a Black professional woman who has been through this, knowing like I want to see everybody. I want to take everyone. I want to be able to do all of the things. But if I don't put down my cape, I'm not going to be able to be here and manage. And so part of that is understanding the responsibility that we have to one another is that we need to go into these fields so that we can better support each other, so that we can have that level of longevity and we can have that like longitudinal care where we know that we'll be able to support more of us because it's never just about us. The picture is always bigger than us. It's about what is it that we can create? What is it that we can leave? How is it that we're going to create those extensions that'll be there well beyond our careers? And if for someone that is looking for a midwife, that's tough. Those percentages are even less. It's difficult. But when you're looking for a midwife, just like any provider, remember that you need to find someone that is going to hear you, that is going to listen to you, that is going to take all of what it is that you would like to see into consideration and is going to provide you with what you want as informed decision, not informed consent. That's a sign off to say you can do whatever you want. Informed decision is being engaged in a relationship with someone that is willing to say, here are all the things that you need to take a look at. Here are some links. Here are some of the studies. If you have questions about that, whatever the case may be. And then ultimately, we can develop a plan together. And I will be honest and direct and transparent with you about the things that I think that we can do and the things that we may not be able to do, and destigmatize all of these issues around birth, because birth really is, it's birth, trust birth, whether it's a vaginal non-medicated birth, whether it's a medicated vaginal birth, whether it's a cesarean section. We have historical documentation that shows that we as midwives did um, cesarean sections and created some of those procedures in Uganda years ago. Years and years and years and years and years ago, right? So it's not like that's outside of the realm of possibility. It's how it is created to be a very scary situation inside of a hospital. You need to find someone that is going to be able to work with you. And midwives are wonderful, and midwives can only go to a certain extent. And then sometimes we do need to have co-care. So that's one of the big things that I would always say is that if you are looking for a midwife, make sure that you have a midwife that has an actionable plan in the event that it has to be a transfer, especially if it's a transfer from home to hospital, and that she has those relationships established. It's always preferable to have a transfer agreement, and make sure that you can have that. And those sometimes can be difficult to achieve. And so that shouldn't rule it out, but just make sure that you at least have a midwife that has very distinct relationships in case there does have to be care. And then also, if you're looking at having a certified nurse midwife in the hospital, make sure you're taking a look at the practice that they work with, and who it is that they do their collaborative care with as far as physicians are concerned, so that you know that those physicians and those OBGYNs that may need to step in the event that you need additional care, have some of the similar same philosophies to be able to help walk you through that next step, even though we are getting to the place where it is becoming more medicalized, because we really, really need our good OBs. We really, really need that support to know that in the event that we have something that is coming up, that we know that our patients are going to be well cared for.
Thank you so much, Jessica, for that rich education. We needed that. We love that. Um, Thank you, community. Y'all still there? Yes. Okay. So before we go into our next panelist, I'm going to ask you a question, Jessica. What is the one thing that you do different that makes a difference?
The one thing that I do different that makes
Only
a
one.
difference, I never forget who I am and where I came from. Yeah, that's the one thing.
That was deep too. It didn't even need a follow up.
Nope, that's it.
Thank you. Thank you
You're
so
welcome.
much.
Mhm.
Jenny. Okay, we got our next panelist up. Okay, Jenny, before I mess this up, Wycliffe, is that how you say your last name? Okay, we're good. Okay, guys, so we now have Jenny Wycliffe is a registered nurse holding a bachelor's degree in nursing, a graduate degree in health administration, and a certification in pediatric nursing. Jenny is the director of maternal infant home visiting at the Center for Family Safety and Healing Nationwide Children's Hospital. Under Jenny's leadership, the maternal infant home visiting program has expanded, increasing the number of home visiting teams from 3 to 8 teams, implementing Nurse Family Partnership and Healthy Families America in 8 counties in Ohio. Jenny's strengths include the development and restructuring of programs that include leadership teams who are accountable, supportive, and dedicated, committed to delivery of evidence-based programs serving children and families. Jenny is passionate about partnering and collaborating with community resources to support parents and caregivers of children in being the best they can be in an effort to decrease and prevent the occurrence of family violence. So whenever you're ready, Jenny, the floor is yours.
Thank you, and thank you for the opportunity. Um, I guess I want to start with my passion is nursing. Khadija just read a lot of different things in my bio, but I say that I'm a nurse first. All those other things are second, third, and fourth. I've always had a passion for working with families, specifically moms and their children. Uh, I agree when Jessica said if the family, if mom and dad are good, or if the parents are good, then the child will be well. That goes with their health. if we can help mom to identify the things in her life that may interfere with her health before and during pregnancy, then we have a better chance in helping her to deliver a baby that is full term and healthy. So that's the goal. When I am developing programs, especially programs that I know that are going to be outreaching into the community, it's my goal to attract, to hire, to retain other nurses, social workers who look like, have experience of, and speak the languages that are within the community that we're working in. That's very important. Research evidence proves that when a mom, when a client, when a patient, when a mom, when a family has someone that looks like them, has similar or same experiences that they're having working with them, then their outcomes are much better. The relationship with that healthcare provider, whether it's in the hospital, whether it's in a neighborhood clinic or a doctor's office, or even if it's in their home specifically, that relationship is so much better. And if the relationship is a positive relationship, if the mom is engaged with that person, that home visitor coming out to their home, whether it's a nurse, whether it's a social worker, whether it's a doula, if it's the community health worker, then their outcomes are going to be better because they're engaged. And if I'm engaged with the person helping me, then that means I trust them. I'm going to listen to them. I'm going to feel comfortable with asking them questions. And it also means that that person has been transparent with me. Transparent. They also been vulnerable as well, especially if that vulnerability is going to support and help that client. So that's the goal. When I'm working with programs and I'm developing programs, I'm trying to develop programs that will attract people, professionals who look like the community that we're serving. Now, is that difficult? It is. It is difficult, very difficult to find Black nurses, to find Black social workers, to find people that are professional and who professionals of color who want to do this type of work. Because it's not easy work. Everybody does not want to go to somebody else's home and do their care. A lot of folks have fear of that, fear of going into someone's home because it's the unknown. And you don't have the same securities or safety nets when you're in someone's home that you would have if you are working in a hospital or working in a health department or working in a community clinic or even a private physician's office or health center. So it's different. So it's challenging to attract people in general, professionals in general, to this type of work. And it's even more challenging to attract people of color because the pool of Black nurses, the pool of nurses who fluently speak other languages is not a very large pool. It's not. And so we have to really work hard. It's word of mouth. The nurses that are here and the social workers that are here who are Black are here because someone else told them about the program or someone in their immediate personal circle was served or benefited from the program and they learned about the program and they want to give back. We have Black nurses who are working and home visiting who were teen moms and they say to me all the time, I get it. That was me when I was 19 years old and pregnant. So I understand what they're going through. And they engage those clients much better, or teen moms much better than someone who has not experienced that or someone who doesn't look like them.
Thank you. So, Jenny, I do have a few questions for you as well. So, if a community member is interested in becoming a nurse, what is some advice that you could give them or something they should be aware of when going into the nursing field?
I would say do your research. Because nursing is not, it's not easy. And you need support. And like Jessica was saying, and like Dr. Dixon also mentioned, you need a mentor. So if you know a nurse, ask them questions. what it's like. If you don't have to start. The good thing about nursing in reference to education is different levels. Okay, to be a registered nurse, you can get an associate degree, which requires 2 years of nurse education. And the education or the facilities providing, or the resources providing that associate degree education is mass. There are a lot of options that you can choose from. You have to have a high school degree, high school diploma to start. Okay. If you choose to go the associate degree track, then once you have your associate degree, there are universities, there are colleges who have the RN to BSN program. And that program might be a year to 2 years, depending on where you choose to go to get that degree. Okay. Or you can choose to go the route getting your bachelor's degree in nursing, your BSN, by applying to colleges that offer BSNs. So there are different tracks. And then once you get your BSN, you can go from having a bachelor's science degree in nursing to a master's or a graduate degree in science and nursing. Okay. Or you can have a graduate degree in public health, a graduate degree in health administration. So there's a variety of doors or opportunities that are presented once you do have your bachelor's of science degree in nursing. I have colleagues who went from having a bachelor's degree in nursing and going to med school and now are medical doctors. So as they say, the sky's the limit. That's true, but it takes work, it takes support, and my experience when I was in school, I was discouraged from going to nursing, and was pushed to go into education. I was told nursing is too hard, education is difficult, you will not be able to endure it. So I suggest you go into education. Education was not what I wanted. Didn't want that. I started out at a large university. It did not fit me, and that was the place that tried to discourage me from being and becoming who I am now. So I had to leave that large place, and I had to go somewhere that was smaller. Education was just as good. It was great, but I was able to connect better in that environment than the environment that I was in. Now, did I still have some challenges and some hurdles when I went to the smaller place? Absolutely. I still had people that did not look like me tell me that I could not be what I wanted to be. But I knew what I wanted, and I was willing to do the work to do that. And along each path, I was presented with or found a mentor every single time. Someone to encourage me, someone to go to when things were really rough and I wanted to give it up because I was tired of people telling me what I could do. And when they realized that I was going to do it, then they made things more difficult for me. I remember, will never forget this, and I've been in nursing for over 30 years, for 30 years plus. And I had an instructor in medical surgery who told me that she was going to do everything possible to keep me from graduating. And I was like, what do you mean? I was the person, when she gave out assignments, I had to learn my patients and the patients of the persons on my team. Every single time, she would drill me on what my patients needed. She would drill me on what my teammates' patients needed. But they didn't have to learn my patients, but I had to learn theirs. So it's that kind of thing. And unfortunately, students tell me that some of that still happens. And it's not that kind of interaction experiences that make people give up, especially people that look like us. Okay. Or people who they are the first generation of college, first generation of someone trying to be a professional. And you don't have that support at home because you don't know, nobody experienced. So they don't know how to tell you other than you can do it, encourage you and push you, but don't really have any information to give you that will help you, to navigate yourself through that. Hope that answers.
Yes, it absolutely did. Thank you so much. So you brought up some really good points, and so did Dr. Cami and Jessica about having a mentor and support for community members who are thinking about going to nursing school, or even they're already nursing school and want to become an OB or want to go to midwifery. With all the, are there already programs in place that offer support to nurses currently?
Black Nurses Association actually has a student chapter. So students who are Black can actually join the Black Nurses Association, and that's a great place to get to find and connect to other professionals. Also, if you're not a member, or if you're not even a student, that's a great place to reach out to the Black Nurses Association's website. Reach out to that organization, and on their website, it gives information about career choices. It gives information about the your education ladder if you want to become a nurse. Most education programs providing education for nursing will have the student organization to support one another. So that's my recommendation. I personally take, I step out, reach out to mentor nurses who are just starting their career. If I know someone is a nursing student, I will reach out to them or say, you know what, here's my contact information. If you need anything, you know, feel free to reach out. Because I remember as if it was 2 weeks ago, what it's like to go through school.
Thank you. And then two more questions, and then we will, we're a little slow on time for questions, but so I will end with like a call to action for everyone. And if you do have any questions that you didn't think of currently, guys, please feel free to email me and I'll be sure to direct those to the appropriate panelists and get back to you all. So, Miss Jenny, what is one thing do you feel that the community needs to know about nursing or nurses in general?
I think the community needs to realize or know that nurses are their partner in their health. Nurse is the person that can be a partner because the nurse can coach you through health. If you're diagnosed with a chronic illness, for an example, the nurse can help you figure out your medications. The nurse can help you figure out what you need to do differently in your life to live longer with that chronic illness. Nurse can be your health coach. A nurse can be your support. And during labor and delivery, the nurse is there is really supportive. Yes, they give medications, but they keep track of what's going on with mom and baby during the process. Often the nurses are actually the coach during the labor when moms don't have a coach. So nurses are your healthcare, I call partner or coach. And unfortunately, I need to jump on another emergent call. Okay, so we're going to have to leave. I appreciate this opportunity. I appreciate listening to Jessica and Dr. Cami. And I hope to see everybody again.
Thank you so much for joining us.
Bye-bye.
All right, Dr. Cami and Jessica, I will, for our last couple minutes, just ask now two questions. So two questions for you all, and then a call to action, and we are going to sign out of this casual community conversation. And that is, how, in what ways do your roles complement each other? And since you guys both have nursing backgrounds, you guys can throw in the nurse in there too. So this is perfect. In what ways do your roles complement each other? And then what do your roles look like in a hospital setting if a mom is with you all? What does your role look like? And you guys can just go.
You taking this one, Kim?
I know. I was like, we work really well together. In fact, like I think over the past, I mean, I've been in Columbus since 2019, and I feel like I've been working with Jessica since probably since then, maybe 2020.
Yeah.
So we've been working together for a long time, and we always say that our collaboration is like kind of the optimal when you think of how people should navigate pregnancy, right? Like I can't. There's too many stories of how many times I've had patients where I've learned so much more about them just because Jessica's texting me, hey, do you hear that this is going on with this patient? And we're working together and getting them the care that they need. And like, it is how care should be done. So I yeah, it's like it was like I feel like almost like we planted you that question. Like that's what that's what it feels like. I don't know, Jessica, if you wanna.
Yeah, I good call. I do feel like that might have been planned a little bit. But yeah, I mean, to Cammie's point, like the relationship that we have with her and a couple of other providers in the city is really how it should be working, right? Like she's able to give us some information about things that she might see that has popped up. We always have an ROA in exchange for, make sure that we can talk about these things. We're able to give her information on things that we're seeing with the patient in between those visits, because she is busy and she's trying to take care of everyone. And so it's a way of being able to make sure that she knows what's going on so that it can be better addressed in the appointment if we're not able to attend the appointment. I mean, even so much far down to like there'll be times that I'm speaking very specifically to Dr. Canny, but like that we've known that one of her people had gone in for some care and nobody had contacted her. So we're the first ones contacting her and saying, hey, you know that so and so is where they are. This is where that relationship really works. And I really want that to be emphasized for the community overall, is that if we are all in this together, then we are all part of the perinatal care team. And it is a necessary component to have all of our aspects to that experience for the family, because that's really the most important thing. And we're going to do our job better when we're able to have a freedom of exchange of information and also a respect of exchange of information.
Mhm.
Because I know that we can do that. Cami works really well with all of our staff. Like we have that experience with her where we can say, hey, you know what? There might be this thing that we think is happening underlying. Can you take a look at it? Or she'll contact us and say, hey, here are some of the reasons why I'm recommending this, and I wanted to discuss this with you and wanted to see if you were aware of this or if you're seeing this as well. And that's ultimately the goal.
Thank you, ladies. Okay, and then I don't know who wants to go first, but give a call to action to the community. And this is like our families. These are disconnected. What is one thing? What is a call to action that we can say to our community members to get involved in the maternal health space or further their careers? What would that call to action or that one thing be?
Oh, that one thing. I mean, I think if you are thinking you might want to do it, right? I mean, I think if you have an interest in it, like we outlined, there's so many different avenues in which you can have an impact on this work very tangibly. For the pregnant people and their families who are in it, if you this is my call to action always is if like you deserve the best care. So if you are somewhere and you feel like you're not being respected, you're not being heard, there are others out there who can take care of you, and we're open and willing. So don't feel stuck somewhere. You have options.
Yeah, actually, I have to piggyback on that's like the biggest thing for me. And I always say it in this way, which sounds sometimes a little challenging for folks to hear, but it's really that you need to remember that your provider actually works for you. The reason that they get a paycheck, the reason that
Mhm.
we get any of our paychecks is because it's either paid through, reimbursement through whatever type of insurance it is. I don't care what it is. There is no difference. And sometimes actually there are some better reimbursements when it does come through Medicaid, but it's always paid through reimbursement. It may be paid money that is out of pocket. You need to remember that the provider works for you. And just like when you interview anybody for a job, you want the person that is going to do the best job possible. And so always keep that in mind. If they're not completing job task, then you have the right to be able to terminate relationship and go on to someone else. And for anyone that is interested in being able to go into this field at all, know that there are multiple aspects. It is not always not about being a midwife, and being a midwife has a lot more to do with things that happen outside of the room than actually being in the room, right? It's not always about having to be a physician, but if you want to be a physician, be a physician. You can go through that track. You can find the people that will mentor you and support you, and know that it will be challenging and it will be difficult, but all great things come from pursuing your passion, right? And know that it doesn't have to be that. It can be anything. It can be being an advocate. It can be being the best friend in the room, right? It can be
Mhm.
being a social worker. It can be a multitude. of different avenues, and all of them are equally important to making sure that we achieve the maternal and infant health outcomes. And even better than that, that we learn how that we can thrive as Black families specifically, but and as families overall, rather than just learning how to survive.
Thank you so much, ladies. I enjoyed you all, and thank you for taking the time out of your afternoon to be a part of this session. And that is the end of today. Thank you, guests, for coming today. Just to put on your radar, September 15th will be the next Lunch and Learn. We'll be joined by a lactation consultant and a postpartum provider. So see you all then. Bye.